This is called retraction. Have you ever watched a stroke patient walk and they have a hard time bringing this leg through because they're retracted on this side? That's called retraction of the shoulder and hip. So we want to bring out and put them forward so that they have more give, so that they're more in a normal position rather than back here. The spasms can pull them back in there, in that retraction area. Okay, any questions? Okay, so we've talked about tone a number of times. Basically, tone is an increase or a decrease in reflexes and spasticity, right? So you have anywhere from flaccidity to spasticity, and we've talked about everybody kind of has different norms of what your muscle tone is. So normal muscle tone. Of course y'all won't get to handle all these babies coming. Did y'all find out about your babies? Mm-hmm. What did you find out at that age?
I don't think so.
You okay? That's fine. And yours is 9 months old and that she's coming?
Yeah, he's coming.
He's coming. Okay, great. So I'll tell Becky so she knows. Okay, so flaccidity is where muscles lack the ability to generate muscle contraction. And so they're just kind of blah. Believe it or not, when people are flaccid initially and they stay flaccid rather than go into a spastic pattern, normally that arm does pretty good. All of a sudden it just wakes up. That's been my experience, that flaccidity, if it just continues over a couple of weeks, all of a sudden that arm, kind of like the head injury patient I was telling you about, he was completely flaccid when I saw him that first time. Saw him 2 or 3 weeks later and the arm was working. So flaccidity is a lack of any muscle, where spasticity, different levels of spasticity, is where you have that increased tone in there and it causes spasm. We're going to talk about the two synergies. There is a flexion synergy and an extension synergy. We're going to start with the upper extremity. We'll cover the lower extremity one in the lower extremity lecture. Synergies are posturing of the extremities in flexion or extension with co-contraction of muscles into stereotypical movement patterns. So you need to know all the different components of the flexion synergy. What is the most common synergy pattern that you see a stroke patient that you just normally see with the upper extremity? Flexion. So they're almost always in flexion, aren't they? So you see them up like this most of the time if they're in a pretty severe flex pattern. The flexion synergy actually is way up here. The only person that I've ever seen up in this position that stays here is a head injury patient that was very severe spasticity. Why does this not stay up? Why do they not stay up here? Gravity. So gravity pulls it down here. But that's normally a typical stroke is to have a flexion synergy in the upper extremity. Okay, so your flexion patterns are you have scapular retraction and elevation, you have external rotation, you have abduction to 90 degrees, elbow flexion, forearm supination, and wrist and finger flexion. So this is it, except it's back here actually. So this is a normal flexion synergy. So you need to know those components of it just so that you'll have those, because you might get that on your licensing exam. The extension synergy pattern you don't see very often with stroke patients, but you do see it with head injury patients. Do you guys know Freddie that hangs around here? Y'all know Freddie? Freddie's an extension synergy. In that arm he has. He has the internal rotation of the shoulder. He's got the protraction. He goes into, y'all probably seen him walking like this, right? That's an extension synergy. So of the upper extremity. So scapular protraction, shoulder internal rotation, adduction, full elbow extension, forearm pronation, wrist extension, and finger flexion. So you've got extension there and then finger flexion. So these are the two upper extremity synergy patterns. But again, the majority of your patients will have a flexion synergy. So you're going to want them to work out of that. A modified Ashworth scale for grading spasticity is just nice to have and be aware of because you might see it on your licensing exam. I have never used it in the clinic, and did any of y'all deal with this at all? Yeah, I really haven't done much neuro rehab, so it's kind of hard to even look at it. But 0 would be no increase in muscle tone, so that would be flaccid. 1 would be slight increase in muscle tone manifested by a catch and release or by minimal resistance at the end of range of motion when the affected part is moved in flexion or extension. So you're just getting a little bit of a catch at the end. Okay, just a little catch at the end. 1 plus is slight increase in muscle tone manifested by a catch, followed by minimal resistance throughout the remainder of the range of motion, less than half. 2 is a more marked increase in muscle tone through most of the range of motion, but affected part easily moved. 3 is considerable increase in muscle tone, passive movement is difficult. And 4 is in rigidity. So those are your Ashworth scale for grading spasticity. Any questions on that? Have y'all, rigidity would be very tight. The spasticity for like a 1 plus, they are able to move through, let's say, 90 degrees of abduction, let's say, but they're starting to, they're getting a minimal resistance once they have the catch, okay? So it's just kind of a knowing what that scale is. Again, I've never used it in the clinic, but you do need to be aware of it. Okay, so Brunstrom stages of recovery. These you need to get a little bit better in your mind, what they are. Mrs. Brunstrom, we talked about her in intro. Who is she? You remember Miss Brunstrom? And the bow baths and all that stuff that we taught you? Brunstrom is a lady who did a tremendous amount of research with stroke patients. So if you see her name, that's who she is. I can't think what her first name is. I believe it's like Scandinavian, but anyway. So if you are at Brunstrom stage of recovery 1, that is flaccidity. There is no voluntary or reflex activity in the involved extremity. So what you'll see sometimes is like you'll have a stroke patient come to you in rehab, and it will say they are at a Brunstrom recovery level of 3. They are at a Brunstrom recovery level of 4, which is good. As they get better, we want them to do more. Okay, at 2, spasticity begins to develop. Synergy patterns begin to develop. Some of the synergy components may appear as an associated reaction. So what would that be? When you're trying to pull them out, an associated reaction would be to pull it back in. You know, if you're doing something and they're getting a response. Number 3, spasticity increases and reaches its peak. Movement synergy of the involved upper and lower extremity can be formed voluntarily. So that means that they have some movement, but they always go into the synergy pattern, okay? Or they do this kind of a thing. A little bit of movement, but it's always into the synergy pattern. Number 4 is where you're starting to see some improvement. Spasticity begins to decrease. Deviation from the movement synergy is possible. Limited combinations of movement may be evident. So number 4 is where they're starting to improve, where they start moving out of synergy. We want them out of synergy. 5, spasticity continues to decrease. Movement synergies are less dominant, more complex combinations of movements are possible. And then 6, spasticity is essentially absent. So they have a little bit of spasm sometimes, but they're able to use the arm. And then 7 is return to normal function. So you do need to kind of get those in your mind. The main thing to remember probably here is that a 4 is where they start to show improvement. If they're a Brunstrom recovery level for the upper extremity 4, then they're starting to come out of it a little bit. They can move a little bit out of the synergies, okay? Okay, so when you're dealing, these actually go with upper and lower extremity. Sandy Kurosaki was the therapist that taught me my NDT class in Little Rock about 15 years ago. And so these are just some different principles of handling. And that's whether you're handling a child, whether you're handling any type of patient that you're fixed to put your hands on. You want to first establish rapport and ask for permission. I actually don't have permission on there because that wasn't a big deal when I first did this, but it is important that you ask for permission to touch people. Because for one thing, it kind of prepares them, doesn't it? So I always ask, like I did some evals yesterday. I said, can I touch you here on your back before I put my hands on them? So you want to be a good listener. Determine what motivates a patient. Probably the most effective, if you have someone that you're working with that likes to play ball, using a ball in therapy is really good, even if it's an older person. You think it's fun to use those little, I can't think what they're called. Nobody? The little things even a little cup, If you can come up with something for them to use that they're used to, that would be a better thing. So what motivates a patient? A really good thing to work with a patient who's had a stroke is golfing, because they have to shift back and forth with a golf club. You'd be shocked at how effective golfing is, and maybe even swinging a bat if you're playing baseball. So just to be aware of what they like to do, mainly because it shows an interest in them anyway. Express both verbally and through touch, understanding, encouragement, confidence, hope, etc. So you don't want to handle them roughly. You want to handle them easy. You don't want them to be afraid of you. Always ask for participation, giving verbal cues that are related to function, not movement components whenever possible. So basically, you want them to do as much as they possibly can do. So sometimes giving them verbal clues before you put your hands on them is good. When you're looking at your therapist setup, you want to use your body most efficiently from the side, back, or front. You need to give needed space and security to the patient. And you need to be able to give visual tactile cues to give the patient a sense of movement. So even tactile cues would be touching them so that they can move their leg forward. Deanna did a lot of that for you on Tuesday when she was doing her class. Observation, always be aware of the whole person regardless of your focus. This actually is hard for me to do. This means that when you are working with the leg and trying to get them to walk, you need to be very aware of their posture, right? Because if they're standing there and you're walking them along and little by little they're losing that posture, you're kind of losing what you're doing. They can't bring that leg forward if they're already in deflection. So you really have to, and Deanna does a great job of that, being very aware of where they're at in space and what's going on with their upper body when she's working on the lower extremities. Give only the control needed, avoiding becoming a support or rest for a patient. Patients are very good at fixing on you. Does that make sense? Have you ever had someone fix on you? You know what that means?
No.
That means that while I'm standing here just talking to y'all, I'm going to start leaning into him. And I'm fixing on him. So you can, patients will do that, so you want to make sure that you're not allowing them to do that with your hands when you're treating them. Does that make sense? Okay. And you start out doing a lot of control, and then you start pulling back. When I was watching Deanna walk Michael Tuesday, I could hardly stand it because it looked like she was going to lose him any minute. I don't know if y'all felt that, but I did. But she was very aware of what he was capable of. but I could hardly stand it. I mean, it was, I don't know, I wanted to get up there. But so as much as you can, you start out with your hands on them a lot, and then you wean them from you, and challenge them to start using their own bodies. Okay. Types of tactile cues that facilitate. Directly over the muscle that caused the movement and possibly in the direction of the contraction. So that's literally doing a little bit of putting your hand on that muscle. She does that well. You can facilitate down here in the quad by putting your hand right here and underneath. There, and facilitate that way. But if you want the quad to work, what this is talking about is actually putting your hand on the quad and facilitating and rubbing, you know, to probably facilitate up would be the way to do it. Indirect or functional cues that give the idea of the movement but not over the muscles causing the contraction. So you can put your hand maybe behind the hamstring when you're bringing the leg through so they can take a step. That's what that's talking about. A functional cue as to what you want them to do with that leg or that arm. And then biomechanical movement or stability cues that give the patient a sensory experience of the movement or stability needed. So this would be actually putting them in that position and putting your hands on them and bringing them through, and that's a lot of control that you're giving them from you. But that's okay, you gotta start somewhere, right? Okay, so here is the sequence of progression when you're starting to facilitate. I'm gonna go get me a drink, be right back.
This one's one. What? Okay. So we're gonna we're behind. We're gonna like so much time. But his is the practice though, right? It's not very great. Wait. So we don't have his bye next week. I'm so confused. I think it is. Because it was red on the feet. Oh, probably. Who knows?
Okay, so number one, you're going to ask them for the movement, right? Take a step out. Step out with your good leg. You're going to ask them to do it and see if they can do it. And number two, if they can't do that, you're going to facilitate with active movement with a light pressure. So you're going to kind of take them through the movement using your hands. Attempt again using different key points or verbal cues if it doesn't work. Biomechanically passive move the patient. This is where you're getting into heavier pressure, where you're actually doing the movement for them. You're not just facilitating their movement, but you're actually moving them through. And sometimes when you start with a patient, that's what you do. You just take them through and you move the leg. Or you shift their body for them, and then you have them step out with a good leg, and you might have to put your hand back behind the knee and move the leg. So that's what that's talking about. And then if that doesn't work, then you change the position. And then we talk mobilization. I'm not going to go into mobilization right now, but sometimes you need to mobilize an area to get more improved posture and things like that. Start with the more ideal base of and symmetrical alignment possible until patient develops more control and options, and then add variety. So that's what you're going to do through therapy. You're going to start them in the static and give them the best position, and then move them in and out of that. Patterns in support of weight bearing are closed chain. So that upper extremity is always in some kind of closed chain position. And it's usually easier to work that arm when we get into actually doing upper extremity stuff, to put it into a closed chain weight bearing thing and work with it, and then move into an open chain, which will be non-weight bearing. And normally the way that you do is you start with isometric, then you go to eccentric, and then you go to concentric. So what I want to talk about is facilitating an arm. What you want to do is set up an isometric contraction so that they can feel what you're wanting them to do. And probably the best way to do that is to have them, you don't want the elbow completely straight, but you're going to just put a little pressure back to them, and you're going to say, okay, push into my hand. And that's how you facilitate them, so that they can start feeling that arm. So you're just putting a little bit of pressure into that arm when you're starting with them. You can have them, I usually have them, go ahead and push out. I have them push out all the way if they're in sitting. Now would I let him sit like that when I'm doing that? He's always going to be in the upright, just what we worked with before. And so that's a good way to just have him start facilitating and feeling where that is. I also have them do it from the shoulder. Okay, push. And so I'll have them push into that arm. And that, because why? Why is that a good one to do? So you are resisting just a little bit to get them to facilitate. So he's having to push back at me because I'm pushing into his hand. I want you to feel that. Please wash your hands after actually, I'm not going to get covered. I'm good. So see, you're just giving them a little bit of a feel where they're having to, you're facilitating them actually using that muscle. And when you've done this, you will, you'll feel that, push against me a little, you'll feel an increase in their muscle tone, and they'll start being able to, I've had them all of a sudden be able to move their shoulder after doing this with them. So this is how you facilitate an upper extremity.
You can start this on the first day?
Pardon?
You can start this on the first day?
Yeah, I would. So if you can have them push into their upper extremity the whole time they're working with you, that's great, because it's going to facilitate the arm. You are pushing pretty hard. Normally your patients are going to push that hard.
The isometric handshake?
Kind of is what it is, except it's, and so you can do your patient, you know, initially just to get that going, have them sit. Did we do any, y'all haven't done any pro bono with this, right?
We got like 2 or 3 weeks.
So,
Are you talking about this?
yeah,
Oh, I don't know.
we didn't, Heather, we usually do it with Heather. When did Heather even come in while y'all were there the 3 days, 3 weeks? You had her. Did you work a little bit with that arm and doing some of that? Of course, she's so severe in that arm. But I will tell you that what we did for Heather when we first started working with her is we got the pain out of the shoulder. So she is pain-free because we did a lot of that. She has a little bit of shoulder movement, but she doesn't have anything much past that. So that's facilitation of the upper extremity, and if you can keep that facilitated the whole time you're working, and as you work on the arm, reality is you're going to work on some arms. You're not going to do it if you're working in rehab, because who does the arms? OT. But if you are doing, you really need to at least facilitate that arm before you start walking with them. If not, they're going to be back here in spasticity, right, in retraction. So you want to kind of facilitate that and get them doing something with that arm before you start gait training. So when you're facilitating the upper extremity for weight bearing and closed chain, you can do all kinds of things. And there's different things to use. Clipboards, putting them on a flat surface, PVC pipe, bedside tables, grocery carts, stools. So I'm going to show you some of this when we go back into lab. Walker with the board laid across the top. That's really effective because it gives them something to put their hands on here so you can get the walker up pretty high and just have them walk with the rolling walker here. So that one kind of is a good one to do. And you're getting them that side forward. Can you see how they're more, if that side is forward, that's a lot better than if it's here. Phone books, boxes, anything that you can grab. A hula hoop's really good because they can hold that hula hoop in front of them while you're walking with them. And so I've used that before. And probably in some of your clinics they have hula hoops. And that's usually what they're for. Give a feel for pushing or holding against the surface by facilitating correctly. This is one thing you need to know. There are a few compensations or substitutions that you automatically need to know. What is the one in the lower extremity that's the most common? What do people substitute for hip abduction?
Flexion.
Flexion of what?
Hip flexion.
Hip flexion. So because the quad is a stronger muscle than the hip medius, they'll turn their hip back and lift that leg, won't they? Have they almost always done that for you?
Mm-hmm.
Yeah. Well, here's another one that you need to be aware of. When people have, you always turn the hand into external rotation to work with it, because when you're here, they can use their internal rotators and their shoulder scapular depression to push up. So that is a substitution that they use in the upper extremity. So just so you're aware of that, because that's something that might be on your licensing exam. But that's what they do. They turn that hand in and they push up here. Okay? So you always want to work with that hand turned out into external rotation.
If they physically can't like push up from this position, is it okay to teach them to push up from this position?
No.
Just to make it functional?
Well, I don't think I don't think it's ever strong enough that you could do it. I think it's such a weird, I don't think it works. I've never seen it work. Okay, so use patterns of support to develop patterns of reach. So these are different things as we get into, one of the things is a closed chain. Wherever, you always want your hand into a closed chain. You can work the hand on the wall. By the way, it's a really good place to work a stroke. Why? Because you got them in standing. And so you can have them in a closed chain position, pushing, going back in. You can turn them to the side, that increases range of motion in the shoulder. You can have them doing some closed chain here, right, where they're pushing away. So that's a good place. Body moves on a relatively stable arm. The arm moves on a body. Body remains stable. Hand remains in contact with the object that moves. So that could be if you put it on a book and you have worked on moving the arm on the body. And then arm and body moving simultaneously, which is a very high level thing. Just worry about the first two. So there's some examples of that on closed chain biceps. Reaching for a door, closing and opening a door is a good one to do. But mainly what? You want to go out of the synergy pattern. So mainly you're going to have them close the door, right? But usually it's going to be a push. Pulling and pushing on the parallel bars, reaching for a pole, just like with Michael. These poles are really good to use, and so you would put this in the affected extremity and have them work with this. You can have them in sitting doing it, and just start facilitating them starting to move the pole in different directions. So they can do that. So that's, what that's talking about. And we did the stuff on the wall. You're really only limited to your own, what's your ideas, you know, and if you've seen some occupational therapy, they have some great ways to work with them, you know, on the different types of equipment that they have. And then the next developmental pattern would be reaching. So a person initiates the reach. Oh, well, this is something you need to know. Remember that you initiate a reach with what? Reach out and see what you initiate with. What do you think?
So reflection?
Well, you actually initiate in your mind with your hand, because that hand's going somewhere. What does a stroke patient do? They do this first, and then they bring their hand out. You ever seen them? So that it becomes a stroke. So you want to avoid that at all costs. You don't want them to move the shoulder and then reach. So you have to tell them, you have to concentrate on your hand. You have to concentrate on what you reach with. Because stroke patients will do this, and then they'll bring that hand out. So a flow of movement should start with the hand to the elbow and to the shoulder. Okay. We'll talk about inhibiting the high-toned hand later. Okay, so go take 5 minutes, and we're going to go do the upper extremity lab. We'll go back into the lab.